listening online. But we are going to get started because we have a really tight schedule this morning. We have, I think it's 7 different presentations, and Santiago gets 10 minutes, but the others are going to be 7 minutes. These are all posters at the ACC, and we have a total of 25 presentations at ACC, 15 posters this year. And I'm just going to, in the interest of time, tell who everybody is that's speaking. And then after each talk, we'll have time for maybe one question. But I would appreciate if you have thoughts or insights about the research to write it down and approach the author later. I think that's really one of the most valuable parts of this, is to kind of get people thinking before they get to the meeting. So the speakers are, in order, Santiago Garcia, who's an associate professor. He's our interventional cardiologist, our newest colleague. He's published over 100 manuscripts. He was a former fellow with us when we partnered with the university, so we're happy to have him here. Next will be Moses, who I think everybody knows. He's a third-year fellow, originally from Kenya. He went to Rush University School of Medicine. He did his residency at a Yale affiliate of the Danbury Hospital, where he was the chief resident. He is going to be leaving us in June and going to Case Western to take up ET. We have Iosif Xenogiannis. That may not be the best spelling or the best pronunciation. He's a fellow from Greece, Medical School of Patras, and he's got a number of abstracts. He was allowed one abstract to present for his work with Dr. Block this morning. We have Aisha Ahmed, who is a graduate of the University of Minnesota, and she's a applicant to medical school, and she aspires to be like Dr. Sharma someday. It's a good aspiration. We have Hiroki Niikura, one of our Val scholars from the Division of Cardiology, Toho University in Japan. We have Amit Sharma, who I think everybody knows, the other senior fellow, graduate of the University of North Dakota, and he will be doing an interventional cardiology fellowship at Beaumont. And then we have Miranda, who is one of our research associates, biomedical engineer from Vanderbilt and an MPH. So these are all posters. So again, write down your thoughts and questions in case there's not time. So first, Santiago.
Well, thank you for that kind introduction. I think we're already 5 minutes behind. I'll try to move fast, and thank you all for coming. 1 hour ahead of schedule, I suppose. So this is the poster that we submitted from the VA when I was still there. As you know, the topic of how to deal with asymptomatic patients with severe aortic stenosis is very controversial. I think it's going to be adding to the controversy with this data. As many of 50% of the patients that have severe AS have no symptoms at the time of diagnosis. And current guidelines recommend deferral of AVR in the majority of these patients until they develop symptoms. Traditionally, I think our paradigm has been that aortic stenosis involves a long asymptomatic period where bad things happen to the ventricle, such as threshold load and LDH. But this latency period has typically been characterized by a very low incidence of clinical events. Recent studies, however, have challenged this notion. The guidelines haven't changed yet. As you can see here, both the European and American guidelines on the left side of the panel advocate AVR, the class 1 indication, only if you have symptoms. The American guidelines have now incorporated this new category of very severe aortic stenosis, peak velocities more than 5, or when failed stress tests, and those are considered class 2A indications for AVR. There is, as I mentioned, data that is emerging that perhaps early AVR is beneficial relative to conservative management. This is on top is unadjusted and adjusted data, and both meta-analyses will point towards the benefits with an early ABR strategy. So we did a study. It's a 10-year observational study looking at our echocardiographic data. We were able to extract all patients that met criteria, at least one criteria for severe aortic stenosis, and we linked this with our medical or CPRS. Then we had a group of residents that assessed for symptoms based on notes and collected all kinds of data, demographic, echo, medications, and follow-up data. We obviously had a lot of patients that had more than one echo during the study period, so we went back to the first one that met criteria for severe AS during the study period. We were not interested in patients that had symptoms or patients that were referred to ABR shortly after this, so we excluded those patients under the assumption that they were symptomatic. And we assessed for mortality, symptoms, and referral to ABR as our primary outcome. The time was, we decided that time zero was going to be the time the echo was done. And the novelty of this study is that we were able to get death certificates on every single patient that expired before ABR. We were able to get those certificates with few exceptions of patients that died out of the state. All the outcomes here are classified using the BARC criteria. We had a total of 1,181 echoes. The main inclusion criteria, the vast majority, as you would expect, were referred to ABR, were excluded because of symptoms. We ended up with about 324 patients in the final study cohort. As you can see, Ivan is texting that he doesn't have any sound that can be fixed. The only difference between the two groups, the conservatively managed groups versus the ABR, was that patients that were managed conservatively were a bit older, about 4 years older. But other than that, there were no significant differences in comorbidities. We also calculated the Charlson Comorbidity Index just to get an idea. This is something that is equivalent to the Apache score for inpatients and for outpatients, and to make sure that these are not patients that are very, very different in terms of comorbidities. Medications were also very similar between the two groups. As you would expect in terms of echocardiographic criteria, people that were referred to ABR had more severe aortic stenosis, but not dramatically so. The peak velocity was slightly higher, mean gradients a little higher, and ejection fraction also observed. Not dramatic differences here. And these are the primary outcomes. So the patients were followed up for approximately 8 years, and the median survival for patients that were referred to ABR was about 10 years, with confidence with an interquartile range between 7 and 9. For those patients that were managed conservatively, the median survival was about 5 years. And when we put on the bar clinical and echo variables in a logistic regression model, two predictors of survival were age. Early decile increase in age, there was a 14% increase in mortality, and aortic valve replacement was strongly associated with the benefit in terms of survival. We're looking at the causes of death, and we had Jenny actually instrumental in getting all the death certificates for these patients. We found that about 47 patients, or 14% of the cohort, died before experiencing symptoms. So these symptoms were documented in the medical records. And of those patients, about 41% had cardiovascular death as the reason for the death documented in the medical records. So almost 50%. And that yields about 1.5 to 2% CV mortality every year. So the conclusion is that among elderly patients with severe asymptomatic AS, a significant proportion of fatal events occur before the onset of symptoms and were cardiovascular in origin. Valve replacement was strongly associated with improved long-term survival. in our study, I guess, highlights how difficult it is to rely on symptoms alone for timely referral to AVR surgery. These are some of the factors that are going to that decision. In general, what's the argument to be made about early AVR? Well, a lot of bad things happen when patients are not yet symptomatic, including left ventricular remodeling, hypertrophy, in some cases as death. So the idea of going in early intervention is to try to mitigate bad things from occurring. Against early AVR, I guess the main argument is that procedures that we do are not without risk, in particular surgery, in adult patients, and that's carries significant risk of upfront mortality, morbidity, and in general, the perception that these patients have good prognosis until they develop symptoms. Now, TAVR may change this because now we can offer a therapy that can fix the bond with the 1% mortality risk. And this is being studied in the TAVR trial. We are going to be enrolling here. But the idea is to include patients with severe asymptomatic aortic stenosis, and we do want patients that are truly symptomatic. The majority of these patients are going to be on treatment beginning to the trial to make sure they don't have any symptoms. And if they do have symptoms, then they will be put in a separate registry. They will be deemed to be symptomatic. If they are truly asymptomatic, then they will be referred for transfemoral TAVR versus clinical surveillance. Study is enrolling already. I think there are 30% of patients. I don't think it's going to be done in 2020. We're going to be part of this soon. So I think this is the only way to answer this question with respect to actually trial. And again, this is the challenge that we face. How do we get symptoms from someone like him? These patients many times come to the clinic in a chair. They don't do a lot. So it's not in my view, it's not about having symptoms. It's about do these patients do enough at home to be symptomatic. Thank you very much for your attention.
should be good now.
Good morning. I would like to thank you for giving me the chance to present our abstract, which is an update from the Progress CTO registry. I do not have any disclosures. Many investigators from different centers, since the data derived from the Progress CTO registry, which is a multi-center CTO PCI dedicated registry. 43 centers participate, mostly from the United States, but also from Asia, Europe, Africa, and Canada. 4,148 CTO PCIs in 4,055 patients were used for the analysis that was performed almost 4 months ago. The database includes about 5,000 CTO PCIs to date. So I'd like to briefly see the definitions, the basic definitions. So a CTO is defined as a lesion without flow that lasts for at least 3 months. Technical success is defined as restoration of immigrate free flow with residual stenosis less than 30%. Procedural success is the achievement of technical success without any in-hospital MACE. And finally, in-hospital MACE is the presence of any of the following: death, myocardial infarction, urgent PCI or CABAT, tamponade requiring either pericardiocentesis or surgery, or stroke. Regarding the clinical characteristics of our study, mean patient age was 65 years. There was a high prevalence of cardiovascular risk factors such as smoking, diabetes, dyslipidemia, and hypertension. Almost 1 out of 3 patients had a prior CABAT, which is associated with lesions of high complexity. And finally, only the minority of the cases took place as an ad hoc procedure, which means that was performed subsequently after the diagnostic angiography without having been previously scheduled. The RCA was by far the most common target vessel with 55%. Mean JCTO score, which is a score that we use in order to illustrate that the complexity of the lesions was 2.4, which is associated with the lesions difficult to deal with. Undergrade wire escalation was the most common first crossing strategy and the most common successful crossing strategy as well. Technical success was 87%, procedural success was 85%, while the rate of in-hospital MACE was as low as 2.4%. So as we already mentioned, the undergrade wire escalation was the most common initial crossing strategy that was used and led to crossing success of 56%. And when another strategy was used, technical success raised to 87%. Retrograde approach was used less often in 40-50% of the patients and mostly in more complex lesions. We can see that the JCTO score, mean JCTO score was 3.3 for the retrograde compared with 2.2 for the undergrade wire escalation. Crossing success was 60%, and when a second strategy was used, the overall success was 82%. Finally, the undergrade dissection reentry technique was the less common initial crossing technique. It was used in 70% of the cases and led to a crossing success of 54%. When a second strategy was used, overall technical success increased to 89%. So our study has some limitations, an observational retrospective study with no core lab analysis. All the procedures took place in high volume centers by operators with expertise in CTO PCI, and maybe the results are not representative for lower volume centers in the less experienced operators. So in order to conclude, by using a combination of crossing strategies, high technical and procedural success can be achieved with a relatively low rate of in-hospital MACE. Thank you.
Iosif, thank you. Why the right coronary artery? I'm curious.
Yeah, it's, actually this is a constant finding among all the studies, all the CTO PCI studies. I think that this happens because there is a preference towards CABATs when we have a chronic occlusion in LAD. This is the explanation, the common explanation that is given. Thank you.
Hello, everyone. Today I'm going to be talking about a novel method of non-invasive screening for patients with aortic stenosis. So as we all know, aortic stenosis is a very prevalent valve lesion. It affects about 4% of patients over the age of 65. And unfortunately, aortic stenosis remains underdiagnosed and undertreated. Only 1/3 of patients with severe symptomatic aortic stenosis receive the life-saving care that they need, which is aortic valve replacement. And aortic stenosis is usually first detected using auscultation. So the primary care physician will usually detect the systolic murmur and then appropriately refer the patient for an echocardiogram. Unfortunately, there are a couple of limitations to this current method. The first is that auscultation may not always be as sensitive as we want it to be. And the second is that echoes are not always available at the point of care. So essentially, there is a need for a simple, cost-effective technique to diagnose aortic stenosis at the point of care in order for patients to be referred to cardiology centers for further evaluation and potentially treatment. So Argentina, they're a company in California, and they recognize this need, and so they developed the Vivio device, which is a small wireless device that you hold against the carotid artery, and it detects the carotid pulse and arterial waveforms, and it sends that over to a Bluetooth-connected device for analysis, so usually an iPad or something similar. And the Vivio device uses sonometry. So when a patient has severe aortic stenosis, the upstroke of their carotid pulse waveform is delayed, and there's more turbulence of blood as it moves through the valve. And so the Vivio device is able to detect this delayed upstroke and also the additional turbulence of blood in order to grade and diagnose aortic stenosis. So we included all patients receiving an echo here at Northwestern Hospital who are over the age of 18 and who consented to be a part of the study. We excluded patients who had a history of carotid hypersensitivity or carotid stenosis. So in total, we had a total of 105 patients. We had 78 patients with no aortic stenosis, 11 patients with moderate AF, and 16 patients with severe AF. And the median reporting time of the Vivio device was only 105 seconds, so it's roughly a little bit less than 2 minutes. When looking at the baseline characteristics, we see the only big difference between the groups is age. Patients with AF were more likely to be older than patients without AF. And then obviously there are hemodynamic differences between the two groups as well. When looking at the confusion matrix, we can see that the Vivio device had a very high sensitivity and specificity. When looking at patients with no aortic stenosis to 78 patients, the Vivio device is accurately able to detect no AF in 72 patients and accurately diagnose aortic stenosis in 6 patients. This gives us a specificity of 92%. And then when looking at the 16 patients with severe AF, the Vivio device is accurately able to detect aortic stenosis in 15 patients, and 1 patient with an inaccurately diagnosed not having severe AF. This gives us a sensitivity of 93.7%. And so the Vivio device uses a special algorithm to grade the degree of aortic stenosis. So if the patient has aortic stenosis, their Vivio score is going to be higher. If they don't have aortic stenosis, their Vivio score is going to be lower. And this box plot shows that the Vivio device is very accurate at grading AF. You can see that most of the patients without AF have a low score. Patients with severe AF have a higher score. And then this is the receiver operator characteristic curve, and it shows an area under the curve of 0.98, which means that the Vivio device is very good at distinguishing patients with AF and without AF. So in conclusion, the Vivio is a novel device capable of diagnosing aortic stenosis patients quickly and accurately at the point of care, and it can be used by a variety of people, whether it's a physician, a primary care physician, or an advanced practice provider. And widespread use of this technology can make a big contribution to patients with AF and potentially help diagnose them, and so they can be properly referred to a cardiologist for further evaluation. Thank you. Any questions?
How does it perform? I'm not sure if you have that, but in patients with carotid stenosis.
So we excluded patients with carotid stenosis, but there was one patient with carotid hypersensitivity that I did consent, and he ended up having a syncopal episode, which was not good, and so we changed the exclusion.
Thank you for coming. I'm Hiroki Niikura. I'm a research scholar of the Valve Science Center. Today, I'd like to talk about my research entitled Transcatheter Therapy of Digital Vital Regurgitation after mitral clip therapy. As you know, mitral clip is known to be effective and safe in patients at prohibited cardiology with severe symptomatic MR. However, residual or recurrent MR after mitral clip may occur in up to 5 to 40% of patients and has been associated with persistent symptoms and impaired survival. For residual MR more than grade 3, as you can see, the incidence of death at 1 year was about 50%. And also, the cause of residual or recurrent MR after mitral clip are variable. Therefore, for those patients, sometimes review mitral clip therapy can be difficult. AVT2 plug has some unique advantage for fluider therapy. It's a low-profile device and configured with 3 same diameter segments. And it has a various device size and less expensive device than other fluider device. So we examine the effectiveness and the optimal technique for transcatheter therapy using AVT plug or AVT2 plug for residual MR after mitral clip therapy. 9 patients with prior mitral clip underwent this transcatheter therapy using AVT2 plug during the first 5 years at our institution. Severe symptomatic heart failure and severe MR was evident in all patients. This patient had a history of 2 mitral clip deployment, but he presented a recurrent severe symptomatic heart failure and severe residual MR from lateral surgery. But there was not enough space for additional clips. So we selected a 16 mm AVT2 plug according to echo findings. First, the rest of the plug was placed in the coaptation of the mitral valve leaflet. However, severe MR was still present. So next, only one segment in the left atrial side and both the west and the distal segment in the LV side with the mitral valve leaflet. Finally, MR was significantly reduced to trivial. Device implantation was successful in all patients. All patients received a single AVT2 plug. In 8 patients, the final position of the plug was 1 segment in the LA side and 2 segments in the LV side. For all patients, there were no adverse events at 30 days follow-up. And MR place and the symptoms of heart failure were significantly improved. On the other hand, mitral gradient was no change after profusion. Device embolization and hemorrhages were serious complications of this profusion. However, those complications were not occurred in this study. In conclusion, our findings suggested transcatheter therapy using AVT2 plug for residual MR after mitral clip may be effective and safe, especially when deployed with only 1 segment in the left atrial side with the mitral valve leaflet. That concludes my presentation. Thank you for your attention.
Any questions?
morning, everybody. Thanks for having me. I'd like to go over my poster for the ACC titled Adverse Outcomes After Acute Aortic Dissection Are Preceded by Changes in a Novel Aortic Constant on Serial Imaging. No disclosures. So the background to this is we know patients that have acute aortic dissection, they survive the initial event, whether they're type A or B, are at high risk for long-term adverse events. One of the things we're seeing is type B patients are basically thought to have a better initial outcome than type A patients, but in some studies around 4 or 5 years, you're starting to see type B patients and type A patients mortality curves crossing. So there's something to say that maybe initially the type B patients do tend to do better, but as you follow them longer, they tend to have more adverse events. Because of the high rate of adverse events down the line, we routinely follow people with clinical and imaging guidelines and follow-up at routine intervals. Various things that we look at on our CTs and MRIs in relation to the aorta to try to figure out how stable people are versus those that are at a higher risk for having adverse events. But these are all imperfect measures. So we need to try to look at ways to better risk stratify people that are going to be at higher risk versus those who are more stable and that we can follow less after their initial event. So really the objective of this study kind of broke up into 3. So we wanted to look at how the aorta grouped over various segments for both type A and B patients. We wanted to see if there were any imaging or clinical risk factors that predicted patients that were at higher risk for adverse events. And then basically we'll talk a little bit about this novel aortic constant and trying to see if this could better evaluate patients who are at higher risk of adverse events. So methods are patients were anybody that presented with an acute type A or B dissection here between 2005 and 2016 that were alive at hospital discharge. Our adverse events were defined as a composite of all-cause death, aneurysm defined as greater than 5.5 centimeters, having a recurrent dissection or needing any type of intervention. And we basically looked at the major and minor aortic diameter, as well as the false lumen diameter at 5 parts of the aorta, ascending aorta, the mid-arch, and the proximal mid and distal descending segments. And essentially we got the first image after somebody's aortic dissection was repaired if they had repair. And then we found a second image which was either defined as the last image that we had or the last image prior to them having sustained an adverse event. So this is where I had to dust off my physics textbook. But basically one of the things we wanted to look at was that the aorta doesn't just grow in 2 dimensions, especially with the diseased aorta. We know that it doesn't grow uniformly. So we basically looked at the aorta and tried to devise basically on the left here, a flow rate equation through an elliptical area. And our flow constant here is C, which basically is a function of the little m, which is the minor diameter, and big M, which is the major diameter. And we calculated this for all of our patients, both initially and then at follow-up. So baseline demographics, overall the patients were pretty well matched. Our type B patients were a little bit older than our type A patients. More hypertension seen in the type B patients. The overall cohort was about 2/3 type A and 1/3 type B patients. Otherwise, we're fairly well matched. And then looking here, there's 3 things. The max diameter here, this is just kind of all segments. Looking at type A versus type B initially, and then at follow-up here. Our aortic constant, once again, for type A is at baseline, and then at follow-up. One thing I'll point your attention here to is that the aortic constant for type B patients initially was bigger than the type A patients. So the numbers for them at follow-up, once again, reflect that they're bigger. And then the false lumen diameter, both at baseline and follow-up. And then we'll go through the aortic growth in various segments of the aorta. So on the left here, you see this is the major, change in major diameter, type A, type B. And then to the right is the change in minor diameter, type A and type B. These kind of teal bars are the patients with adverse events, and the red patients are those without adverse events. So in the type A patients, you can see there's more growth across really all segments of the aorta, patients with adverse events. But one of the areas where we're noticing more growth is in basically all parts of the distal the descending aorta, For type B patients, not quite as clear of any type of change in the aorta, both initially and at follow-up. Looking at the minor diameter, kind of similar things here for the type A patients. There's more growth really in all areas of the aorta in relation to minor diameter. in type A patients, and once again, not quite as clear of any pattern here with our type B patients. Looking here, so this is going to be our, I believe my aortic constant figure didn't make it up here, but this is looking at the false lumen diameter here. Once again, with our type A patients, especially in the 3 segments of the descending aorta, you see much more growth of the false lumen in those patients with adverse events here in the teal compared to those in the red. And then also looking at type B patients, we don't really see as much of a difference here in the false lumen diameter. When we did our univariate analysis, really the thing that we saw was having CAD was one thing that was significantly associated, but really didn't find much else here. We had 2 different models of a multivariate analysis. So model 1 on the top here, our aortic constant rate has a very significant p-value as well as the maximal diameter of the false lumen for predicting adverse events that follow up. Model 2 at the bottom here, false lumen rate, which is basically the rate of change in the false lumen, was also predictive of adverse events. And so to just kind of go through this, basically we had 29 adverse events in our 118 patients, and then once again, the maximal diameter of the false lumen, the rate of growth, and the aortic constant were predictive of adverse events that follow. So basically, in conclusions, we have differential growth across different segments of the aorta in both type A and B patients. The baseline false lumen diameter and the change in aortic constant are associated with adverse events. So this might allow us to build a predictive model that looks at things other than just the major and minor diameter in following those patients and assessing who is at higher risk. Those are my acknowledgments.
Amit, nice job. So you modeled the false lumen as an ellipse?
Well, so we did that with the false lumen. We looked at just basically the diameter of it over time. We looked at the aortic constant using the major and minor diameters of the overall aorta in all the 5 segments. The false lumen we took just as the diameter. So the aortic constant was just for the major and minor diameters of the aorta.
Okay.
Great job. How many patients of the type A had connective tissue disease that was kind of confirmed? And then was there any difference, in the pattern if you look at the ones who get marked on or
Right.
versus not?
Yeah, so in all the other studies, that's been predictive. I think in our study, we had 3 or 4 of our 118 patients that had connective, I think it was 4 that had connective tissue disease. And in the univariate, it didn't shake out, and I don't know if that was just such low number. Yeah, such low numbers of patients. Yeah, but that's traditionally what we see is they just tend to do worse.
All right, I'm going to be talking about predictors of appropriate ICD utilization in patients with arrhythmogenic right ventricular dysplasia cardiomyopathy, ARVDC. We have no disclosures to report. So ARVDC is a process of fibrous or fatty replacement of the myocardium, and that can lead to congestive heart failure or life-threatening ventricular arrhythmias. And there are limited recommendations on the use of ICDs in patients with ARVDC, particularly for primary prevention of sudden cardiac death. These recommendations are based on a few studies with limited data, and here we have MRI images of a patient without ARVCD and a patient with ARVCD. So the 2017 guidelines for the management of ventricular arrhythmias and prevention of sudden cardiac death recommends ICDs for these patients for the secondary prevention of SCD or for those with significant ventricular dysfunction. They also say that an ICD can be useful in patients with syncope presumed due to ventricular arrhythmias. So our aim was to identify characteristics that were associated with appropriate ICD intervention in these patients who underwent ICD implantation for primary prevention of sudden cardiac death and to compare those to the established guidelines. So we started with our genetic arrhythmia center registry, which includes 340 patients. And of those, 68 have been formally diagnosed with ARVC and 60 have had ICDs implanted. And of those 60, 47 were implanted for primary prevention of sudden cardiac death. We looked at the cohort of 47 and compared those who ever had appropriate therapy to those who never had appropriate therapy. We had 10 patients, or 21%, that experienced appropriate therapy. Median time for the first therapy was 1.7 years. And our main finding was that lower RV ejection fraction was associated with appropriate therapy. Notably, we didn't find significant associations between syncope or documented NSVT and appropriate therapy. We had 21% of patients that experienced complications from their devices, and most of these were due to lead failures or recalls, and 17% experienced inappropriate device therapy. So these are the main variables that we looked at. Family history of SVD, documented NSVT, and syncope were not associated with appropriate therapy. We did find an association between a family history of ARVC and appropriate therapy, and actually a family history of ARVC was less common in those with appropriate therapy than in those without appropriate therapy, which means that family history alone probably isn't a good independent indicator for an ICD. And then at the initial CMR, we found that RV ejection fraction was lower in those with appropriate therapy than those without appropriate therapy, 45% compared to 56%. And this is a closer look at the difference in RV ejection fraction between those with and without appropriate therapy. And then RV end diastolic volume was not different between those with and without appropriate therapy. So in conclusion, our findings are in accordance with the 2017 guideline, as we found right ventricular ejection fraction was associated with appropriate ICD use. However, further investigation needs to be done into LV involvement and other CMR characteristics like delayed enhancement and their association with appropriate therapy. Overall, our data support the use of ICDs for primary prevention in these patients, particularly those with advanced right ventricular involvement. However, due to the high complication rate, patients still need to undergo a thorough discussion of risks and benefits of ICD implantation before they're considered for implant. We'd like to acknowledge MHIF and Medtronic for their support. This is what the poster looks like. Thank you.
We do have some time still, yeah, if there are questions, specific or general.
Nice presentation and data. Did you look into fibrosis of the left ventricle, involvement of the left ventricle as well?
We haven't looked at that much yet. We're having an intern this summer who's going to be looking more closely at that. Yeah.
Were there any deaths?
We had one cardiac death and one non-cardiac death in the group.
With an ICD or without?
The cardiac death had an ICD.
I think it's really interesting because a lot of centers, and it's second nature for us to use MRI, and but a lot of centers, it's still sporadic as to other centers using MRI, but gated CT, the Hopkins group still uses echo predominantly to follow up and things. So here you have a data point using MRI, and additional characteristics that we'll look at. It's revolutionary, right? Because it classifies the disease better, it identifies earlier stages of the condition, and now you have an actual predictor of increased utilization of activity. So very useful data.
I wonder if you would use also RV in systolic volume might discriminate better, because in end-diastolic everybody's going to be somewhat dilated, but the end-systolic takes into account the function as well. So.
Yeah. I think what's interesting that RVF actually wasn't that low, right?
Yeah.
So I think that's kind of a really good clinical, you know, it was 47%. It's pretty much,
and it may be
only
a predictor that you may not necessarily notice on echo.
Absolutely.
So that's very important as well.
I do think like maybe just the function would be good. Like I don't know if correlating it with TAPSI. I know we're doing a lot of TAPSI. It will be interesting to go back for these patients and see whether we could see what the TAPSI was, because I think still a lot of centers can't do an MRI just like we can on a Friday evening.
CMR as
Yeah.
well.
Yeah, and maybe we could do both, because I think that correlates actually well with the CMR.
Thank you.